Thank you, Miloš. Good afternoon, everybody. Thank you for being here. And I would like to thank also Professor Jäger for leaving me his favorite lecture, and I promise him that I will do my best. Okay, here's my goals for this talk. And first of all, I would like to make this talk enjoyable for you at this time of the day, because I believe that if you enjoy this lecture, you will remember more and you will learn more. Then I'm planning to motivate you more about perfusion-weighted imaging. And then after that, I will mention about the rationale, how we can select the perfusion method, and what is the role in tumor grading and role in prognosis. To make my talk a little bit enjoyable, I will spoil my talk with such kind of artistic images. The reason for that as a woman radiologist, I like color very much, and that is the reason that I try to be more focused on functional imaging technique. And among this technique, the perfusion-weighted imaging actually is my favorite, and not only because of its powerful technique, but also give you information for angiogenesis. But of course, our duty is not just enjoy ourselves, but also we have to really think that perfusion-weighted imaging is really necessary for the clinical workup. So therefore, I would like to ask you, how many of you think that really perfusion-weighted imaging is necessary in clinical management of brain tumors? Can you raise your hand, please? Okay, more than half, I guess. So actually, while I was planning to make a study about this, then suddenly I encountered with this article which has been published in Imagenologia, and they asked us exactly the same question that I asked you, and they showed that perfusion-weighted imaging has great impact on management of brain tumors, and they found that the confidence in status of assessment of brain tumors increased in 40% for neuroradiologists and 56% for treatment plan. And they concluded that just because of the perfusion-weighted imaging, the management plan changed in 8.5%. So finally, they concluded that perfusion-weighted imaging is really necessary for management of brain tumors. Let's go to other part. First of all, I would like to mention about the rationale of using perfusion-weighted imaging in brain tumors. We know that angiogenesis is a hallmark of tumor growth and metastasis, and therefore it has the same effect as the sun affects the trees. So this illustration is, although very classic and old, but still is very nicely depicted that as you will see, as you can get the increased grade of tumor, you start to see increased permeability, numbers, diameters, and wall thickness of vessels. So when you get glioblastoma multiforme, you will get glomerule-like vessels, as you can see at this illustration. So therefore, we always give contrast material when we are dealing with brain tumors. But actually, the enhancement that we see it doesn't represent angiogenesis, but mostly give us the knowledge of primarily disrupted blood-brain barrier. And therefore, many studies show that both conventional CT and MRI actually are not sensitive enough for tumor grading, and the sensitivity has been ranged about 55 to 83. And again, up to 45% of non-enhancing glioma are actually malignant. Therefore, in the literature has been documented that the conventional MRI actually is not necessary. But literature findings, of course, they are important, but our experience are also important as documented. So I would like to show this patient that he was milkman and he was presented with a headache. So this is his conventional MRI finding. Then you can see that there is a round-shaped tumor that shows any contrast enhancement. And our neurosurgeons asked us if this case was malignant or not. Then we recommend them to get the perfusion-weighted imaging. And you can see that at this part of the lesion, there is an increased perfusion, which represents most probably the malignant part. And we recommend them to take the biopsy from this part. And the pathologist proved that this was a grade 3 glioma. Look at the other case, which is a grade 4 glioma. And you can see that there is a ring-shaped enhancement. But when we look at the perfusion-weighted imaging, we can see that the actually increased perfusion is not at the site of the enhancement, but at the periphery of the enhancement. That does mean that actually the infiltration is around the periphery of the contrast enhancement, and it showed the malignant part of this tumor. So as many study, our study also showed that degree of RCBB elevation is a strong predictor of tumor infiltration, as you can see in this case. And therefore, it's also very important for tumor grading and therefore survival. Now I'm moving to the technical part. I will not go into detail, but I will briefly show that there are numbers of techniques that you can use to get the angiogenesis information, as you can see in PET, Xenon CT, SPECT. But as radiologists, we prefer MRI and CT perfusion. There are numbers of techniques that you can use both for CT and MRI. I will not go into the detail again, because I already mentioned in previous year in ECR, you can even find in archives, or if you give me your email, I can send you later on. But you can choose one of these techniques to get this information. Just to show you a brief overview, we know that you can use CT perfusion, but in my clinic, generally I prefer MRI perfusion due to the radiation and limited coverage. But even if you get CT perfusion, you will get almost equal information, as you can see in this patient. So we image this patient both in CT and MRI, and you can see that it gives us almost equal perfusion map that show high perfusion around the periphery of the lesion. Even in ASL map, you can see the increased perfusion around the periphery of the lesion, and this case was a malignant lesion. Again, you can choose either ACL or bolus technique. Actually, personally, I prefer ACL, although we are comparing in almost all cases with contrast-enhanced perfusion-weighted imaging. This is because this is completely non-invasive technique, and it is insensitive to blood-brain barrier disruption. And sometimes we can get errors in bolus technique. In the study that I mentioned just at the beginning of my talk, the author also asked the neuroradiologists and treatment team if they prefer ACL or contrast-enhanced bolus technique of perfusion. And most of the neuroradiologists actually both equally agree that both techniques are necessary and useful, but most of them prefer ACL instead of other techniques. So after the mentioning about methods, I would like to go into more in detail in tumor grading. We know that glioma grading is very important because the treatment plan and defining prognosis also important for those cases. But unfortunately, histopathology suffers from some inherent sampling errors, such as sample size and location. And even in pathologists, there are inter-observer variability of pathologies, which exists up to 30%. When we look at these cases, which shows different part of the lesion that has either increased and low RCBB value, if you get the biopsy from this part, probably you will end up with a malignant tumor. But if you get your biopsy from this part, which enhance highly, there is a big amount of possibility that you can end up with necrosis and also insufficient data. So we know that malignant tumors generally are very heterogeneous, and therefore they contain both low and high-grade tumors. And for this reason, I recommend you to use perfusion imaging for treatment plan and also for biopsy planning. So as we have higher grade of tumor, we start to see more amount of angiogenesis, which also represented as microvascular density and vascular endothelial growth factor. So when we look at the literature finding, we know that if you have a lower value of RCPV value, most probably you will encounter with lower grade of tumor. But if you have a RCPV value which is higher than 1.3, most probably this case will end up as a malignant tumor. This data is our data. Actually, we presented in Frankfurt in ASNR, and you can see that both ACL and RCPV provided almost equally same sensitivity values with using 1.5 as a cutoff value. But in our previous study that we published in Academic Radiology, the RCPV sensitivity was lower comparing ACL. This discrepancy arises because of that we have more number of oligodendroglioma in our previous study, which we didn't have in our current study, that many of oligodendroglioma. So oligodendrogliomas are actually exceptions. They don't follow, as Professor Jäger mentioned, that they don't follow the rules. They are naughty tumors, and we have to be careful about them. And we know that oligodendrogliomas exist up to 20% among brain glial tumors. So in many studies has been documented that even if the patient is benign, in case of oligodendrogliomas, we will end up with higher RCPV value. Therefore, as Professor Jäger mentioned, that we cannot rely on perfusion data for oligodendrogliomas, but we should use either low ADC calcification or strength enhancement as a predictor of malignancy. As you can see in the sample, in the case of oligodendrogliomas, sometimes you can encounter increased perfusion, but this increased perfusion does not necessarily imply the malignancy. As oligodendrogliomas, there are some other tumors can have increased perfusion despite their nature that are benign, such as meningioma, choroid plexus tumors, gangliogliomas, and juvenile pilocytic astrocytomas. Now I am moving to the last part, which is prognosis part. And we know that there are so many determinants for tumor prognosis. And tumor volume, extent of resection, histopathological grade, and of course, preoperative RCPV are the most important ones. There are some other factors that are less important, but still we have to keep in mind. We know that for low-grade gliomas, prognosis can range for 5 years from 27 to 97. And you can see that this is actually a very large range. So it should be some other predictors that we can define. So many studies, as in this study, show that preoperative RCPV actually is an important prognostic factor and is connected with survival. Look at this nice graph. In cases of low-grade gliomas, when they were using the cutoff value of 1.7, as the patient has a lower RCPV, they get longer survival. And in case that has higher RCPV value, the cases get shorter survival. So RCPV is really good indicator for prognosis and survival in low-grade tumors. Once we had a patient who was a fisherman, and he presented as left-sided weakness. And you can see in his MRI that he didn't have any contrast enhancement, and it looks like a benign tumor. But when we get perfusion-weighted imaging, again, it supported our opinion about conventional MRI. And we get the RCPV value of 1.1 in this region. And this case was a grade 2 tumor, and still we are following of this case. Again, another grade 2 astrocytoma, a typical case. You can see that it's infiltrative tumor, as you can see here. But on RCPV map, there is no any increased perfusion. So again, another grade 2 or benign astrocytoma. But since perfusion-weighted imaging is very important, we prefer, in our clinic, we prefer to follow low-grade tumors with perfusion, since perfusion imaging can identify areas of malignant transformation before conventional MRI. And it has quite high sensitivity and specificity. Now I am moving to high-grade tumors. We know that grade 3 gliomas, they have really poor prognosis. They don't have necrosis pathologically, but they live up to 2 years. For grade 4 gliomas, that it's even worse, and they live up to 1 year, and 2 years of survival rate is only 10%. So our finding is even more important in such patients. Again, another publication that they use RCBV value as the cutoff value is 2.8, and they again show that if the patient has higher RCBV value, they have longer survival comparing the patient who has lower RCBV values. Of course, we have to support this observation with our clinical experience and look at those patients who both of them were grade 4 gliomas. And in this case, who has a RCBV value of 3.5, the patient survived 18 months, comparing this patient who has a higher RCBV value and shorter survival. Our observation also supported by the literature, as in nice literature in nice article that has been published in AJNR, they show that RCBV actually is closely correlated with tumoral microvessels area, and they compare both total vessel area with RCBV value and also survival, and they find the same information as I showed you before. Now I would like to this patient who was an 11-year-old boy. He was a history of resected Ewing sarcoma, as you can see in PET imaging here. And the patient has multiple level of bone metastasis. And suddenly this case presented as an acute onset of neurological deficit. He has a hemifacial spasm at that time. And we imaged this case with CT firstly, and you can see that on the left basal ganglia, there is a hypodense region which is not nicely delineated. Then we recommend this MRI, and you can see that again on the left basal ganglia, there is a round-shaped lesion which has a piece of hemorrhagic product. But when we look at the diffusion-weighted imaging, we can see the peripheric restricted diffusion. But on contrast-enhanced T1-weighted imaging, there is not so much enhancement, only faint enhancement that exists. So the clinician asks us if this patient is metastasis or a stroke cases and hemorrhagic cases. Then we recommend them to solve this problem by perfusion-weighted imaging. So you can see that on the second day, there is a little bit more pronounceable hemorrhage on non-enhanced T1-weighted imaging. And FLAIR imaging looks almost the same, but neither ASL nor RCBV-weighted imaging, there is no any increased perfusion. So at that time, we thought that this could be a hemorrhagic stroke, but still we weren't comfortable completely comfortable due to the clinic and also conventional imaging finding. So we recommend for this case close follow-up. The reason for our explanation it was we know that from either our experience and from literature, the metastasis cases have even higher RCBV value comparing the malignant lesion. But in 10 days, when we imaged this case in 10 days later, you can see that the lesion gets a lot bigger than the previous time. And you can see that still there is a restricted diffusion around the periphery of the lesion. And when we look at the contrast-enhanced T1, it looks like completely the same as metastasis. So when we look at the perfusion-weighted imaging, you can see that on the ACL map, you can see the increased perfusion around the periphery of the lesion. But when we look at the contrast-enhanced perfusion-weighted imaging, it gives you erroneously unincreased perfusion. So as in this case, if you have a hemorrhagic product or a more complicated lesion, you have to be careful and you have to be aware of all artifacts that, as I mentioned in that case. So I would like to conclude that perfusion-weighted imaging is still evolving technique. We need more experience, more publication about it. But overall, it's improved the management of gliomas. And we have to remember that low-grade oligodendrogliomas could be falsely graded as a higher grade of tumors. They are naughty tumors. We have to be careful about them. But as a take-home message, I would like to conclude that the higher the perfusion, the higher the grade of glial tumors, the higher perfusion, the shorter survival, and the worse prognosis. So the photos that I show you as patient, they are, of course, does not belong to real patients, belong to this Turkish photographer. He is a very famous Turkish photographer, Ara Güler. And I would like to thank you with my colorful photos, and I would like to wish you a colorful evening and colorful congress. Thank you very much.